Hi there, my name is Grace McCall and I'm one of the consultant paediatric nephrologists working here in Royal Belfast Hospital for Sick Children, and I'm going to talk to you today about paediatric acute kidney injury. So just an overview of the talk, I'm going to talk to you about the background of AKI, its definition, pathophysiology, using a case to talk through principles of history, investigations and management, AKI outcomes and follow-up, and why is it important. So firstly, what is AKI? So it's the reversible loss of normal renal function, and it's recognised by a reduction in urine output and an increase in serum creatinine. And that results in a reduction in your glomerular filtration rate and will affect regulation of fluid, acid-base balance and electrolyte balance. The reversible element of that is arguable, and I'll highlight why that is later in the latter aspect of this talk. Chronic sequelae is under-recognised from the point of view of AKI. It was traditionally very much thought to be entirely reversible. However, emerging evidence challenges this and supports a strong link between AKI and chronic kidney disease. So looking at the incidence and mortality associated with AKI, so the largest study was in North America, and that looked and found that there was a markedly higher mortality rate associated with AKI, and that's really the largest study that there is in place. More locally, there was a study in Royal Manchester Children's Hospital in their PICU, looked at the time between the relationship between AKI and AKI biomarkers. And that identified that 49% of their children had an episode of AKI, which is fairly significant. And more recently, there was a study carried out through the British Association of Paediatric Nephrology, and that was over 6 centres looking at serum creatinine values. So they had over 57,000 creatinine values, and they found that there was a 10.8% incidence of AKI. However, only 27% of these episodes were recognised, and there was failings in very basic things such as daily weight urinalysis, things that are simple and that we could very much improve on. And this again is just to highlight an observational study from America comparing, they looked at and compared the different definitions of AKI, and they very clearly identified it was associated with a greater mortality and length of stay, both in ICU and outside of the ICU setting. So where did this all come from the AKI perspective? So there's a sort of a seminal report, so the NC Pod report of 2009. There was a marker for change with regard to acute kidney injury. It was done in the UK, and up to 100,000 deaths each year in hospital were associated with AKI. Up to 30% of those could have been prevented with right care and treatment. These findings from the report showed systematic failings in adult AKI and recognised that changes in practice needed to be made to improve our patient care. This led to an NHS patient safety alert, as you can see in the centre. And that led on to Think Kidneys, which I'm sure some of you are aware of, that was produced in 2015. And that was a national NHS campaign to improve the care of people at risk of AKI, including paediatrics. And this is just that document and the BIPN flow diagram for AKI. That was developed by representatives for the paediatric renal units, and the output was a consensus document highlighting children at risk of developing AKI, advice regarding investigation, management and tertiary service referral criteria. So thinking again about the definition of it, so there has been variable attempts to do this over the years. Primarily, RIFLE was very much adult driven, so risk, injury, failure, loss and end stage disease. And this was carried out in 2004 by the Acute Dialysis Quality Initiative Development Group. That led on to Paediatric RIFLE, so P-RIFLE, and that looked more at changes in glomerular filtration rate rather than just serum creatinine alone. And then more recently in 2012, KDIGO took that forward, and they amended the definition with regard to changes in serum creatinine and both your urine output, looking at those children who didn't have previous blood results with specific upper limit reference ranges. And again, that's just to highlight the different ways in which it's been classified, and KDIGO tends to be the one that's more recently used in literature, which is the one that I have circled. And again, that's just a slide to show the definition as per KDIGO, stages 1, 2 and 3, 3 being the most severe, 1 being less so, and that table of agreed age-related intervals. So that child that comes into hospital who's never been in before gives you an idea of what their creatinine should be. And that's also in the Think Kidneys, so if you're looking for a reference point, it is there. So the limitations of this, diagnosis of AKI in children is caused by for variable reasons, and it's not distinguished in the classification. Diagnosis is just relied upon from a creatinine and a urine output perspective, but serum creatinine is affected by a number of different factors such as sex, muscle mass, age, metabolic state, and generally it's a poor biomarker. So a big point that I want you to remember is that creatinine levels only rise once you've lost 25 to 50% of your renal function. So there are other biomarkers out there which are beyond the scope of this talk today, but are certainly a research point for future. Looking at it onwards, the measurement of urine output, very difficult in children. People do struggle with that, so it's a problem. But despite these limitations, estimation of serum creatinine and urine output are the most practical way in which we can define AKI at this current time. Pathophysiology then, so this is just a table to try and talk that through with you. So you get a primary insult that causes acute tubular damage, and it's accompanied by a loss of the ability to reabsorb filtered solute. This resulting vasoconstriction in an attempt to improve the GFR can perpetuate further renal damage such as obstruction and inflammatory processes. And this is a table really to look at the etiology of AKI. And it can be classified, and I've tried to classify it into three different sections. So functional, leading to reduced blood flow, intrinsic or obstructive. And this is important for a number of reasons, and important to highlight that AKI secondary to hypovolemic dehydration is the most common cause worldwide. So just try and work through that table and see where it is you think that your child fits in and go from there. So talking through a case then, so this is a 4-year-old girl. She had a 3-day history of vomiting and diarrhea. She had a history of temperatures at home, limited oral intake, parents unable to quantify, as is so regularly the case when we see these children, and a decreased urine output. Again, couldn't quite put their finger on when she had last passed urine. Looking at her past medical history, so she had a history of congenital cardiomyopathy. She had a cardiac transplant in July 2016. As a young child, she had recurrent urinary tract infections. This culminated in an E. coli sepsis, aged 2 years of age, and at that time she had a documented AKI. This led on to her to develop CKD stage 3, probably partly from a transplant perspective, but also because of insults to the kidney, and she also had hypertension. Looking at her medication history, she was on tacrolimus, alpha-calcidol, cotrimoxazole, atenolol, sodium bicarb, Cytron and Abidec. And just to particularly focus your minds in there on the tacrolimus with regard to her medication history. So history is really important from the point of view of AKI, and it's important that you do take the time to do that. So think about the fluid intake. Has there been a reduction? What about their urine? Again, is there a query about obstruction? And is it concentrated? Is there blood in it? Temperature, you're thinking about insensible losses. So if you've got GI losses plus temperature, you must think that actually that renders them at higher risk of dehydration. Your normal history points, as you always would, but really focused in on that medication history. So nephrotoxics, have they had Nurofen for their temperature rather than just paracetamol alone? And always think outside the box from a systematic point of view. Is there something else more unusual going on here? So do think about rashes and joint pain and recent tonsillitis and that side of things. It's important to consider that children who are dependent on others for fluid intake can also be at increased risk of AKI. Non-ambulatory children and those with a low muscle mass will have a lower baseline creatinine, and that may mask their creatinine rise if not compared with baseline levels. So don't just look at the warning scores on your lab system, look at the trend. There are several high-risk scenarios for AKI along with specific underlying medical conditions that render children at risk of AKI, and they're in this table, and again they are within the Think Kidneys document. A thorough drug history, as I've already said, is really, really important, and consideration of potential nephrotoxic medications must be undertaken. And this table highlights common agents that may need to be stopped, may need to be dose reduced or monitored very carefully. It's not an exhaustive list, but one that I find can be helpful just in your general daily practice. In the setting of AKI, your nephrotoxic medications should be stopped if you can. and if you cannot, undergo dose reduction in line with their estimated glomerular filtration rate. And this needs to be reevaluated as their renal function changes. So if your eGFR gets worse, you may need to readjust those doses again. If it gets better, you may be able to relax it slightly. So back to our case. So this little girl, she was tachycardic. Her rests were fine, her stats were fine, but she was also hypotensive with a blood pressure of 88/56. Normally sits with a blood pressure of 120 to 130. Of note, her weight was down 1 kilo from her recent clinic appointment, and that is important. If you can get a previous weight, that's very useful. She was lethargic but rousable. She did appear to be dry on clinical documentation, so dry mucous membranes, not edematous but cool peripherally, and had a cap refill of in and around 3 seconds. Thermal pulses were present. She had good air entry. Her tummy was nice and soft. No other rashes, meningism or anything of concern. And her initial gas there, as you can see it, she had a metabolic acidosis. And of note, her BM was 2.2. So how do we assess these children with AKI? Attend to their life-threatening features first. So think about your ABCDE approach. So oxygenation, fluid status and electrolyte derangement. Evaluation of fluid status is essential to clinically determine if they are hypovolemic, euvolemic or hypervolemic. Make an attempt at that. It is difficult and fully appreciate that, but do make an attempt. It makes it easier for people coming behind you to see if your changes have been effective. Your blood pressure should be performed manually on an upper limb. You may need to consider doing a Doppler blood pressure if you've got a smaller child or a baby for a more accurate reading. A height measurement when working out your blood pressure centiles is needed. However, I appreciate that if a child is very sick, this may not always be possible. So clinical features consistent with fluid state. Okay, so I've tried to split this up again into 3 sections and make it easy for people to go through and try and make that assessment. And this is all things that you will already know, but it's just to try and quantify that for you in a succinct way. So looking at your child with a dry mucous membrane, sunken eyes, prolonged cap refill, our child very much fits into that picture of being hypovolemic. In that situation, you're wanting to think about giving a fluid bolus of 10 to 20 mils per kilo, either of 0.9% saline or plasmolite, depending on your local fluid guidelines. For those children that don't quite fit into either hypovolemia or hypervolemia, you may feel they are euvolemic, but they can still undergo a fluid challenge, which can be between 10 to 20 mils per kilo, but maybe given over a slower space of time, such as 60 minutes, to see how they respond to that. Does it improve their observations or does it improve their urine output? And then there are the children that are hypervolemic. So thinking about those that are tachycardic, hypertensive, raised JVPs, difficult in children but can be present, gallop rhythm, edema or a palpable liver. Have to be more judicious with your fluid in that situation. You can certainly give an IV furosemide challenge to see if it is effective, but these children are the ones that do run into difficulty quicker, so do consider referral to ICU or consideration for renal replacement therapy at an earlier stage. So for our young lady, she had 40 mils per kilo of sodium chloride. Her systolic blood pressure remained low despite that, at less than 100. She had a 10% dextrose bolus in light of her BM. And we decided from a fluid perspective that she was dehydrated. So therefore she had a 10% deficit. She was catheterised and placed in a strict fluid balance. At the time when she came in through the emergency department, she was felt to be very drowsy and she was commenced on tazocin and acyclovir. And I raise that from an acyclovir perspective because that is a drug that is very, very much documented to have issues with exacerbating AKI. So be careful if you think that a child has encephalitis and you need to treat them, that's fine, but make sure you renal dose adjust it and make sure you review that on a regular basis. And we can see for her initial results there that her creatinine was up at 171 with her baseline being 80, so a marked increase in her creatinine. Her potassium was okay, her chloride was low, her bicarb was low, her coag was slightly off, and importantly just to mention her TAC level, so it was 4.8. It wasn't high, that's acceptable from a cardiac transplant and a renal transplant perspective, but always think about it in these children. That gave her an EGFR of 21 mils per minute, and if you put that in perspective, you're thinking about dialysis when you have an EGFR of 15 and below, so a marked decrease. AKI investigations, so clinical history and biochemical investigations along with renal ultrasound are helpful in determining the cause of AKI, and this table is just a way, I know it's a busy slide, but it demonstrates initial investigations that should be performed in all these patients, and further investigations are then warranted dependent on the suspected diagnosis. If you're concerned, discuss it with your local paediatric nephrologist. Just to highlight a few things, urinalysis is a really easy, quick test and done poorly. Please do it. Please send off urine for a protein-creatinine ratio. First thing in the morning is the most reliable, and it gives us a good idea of losses from the kidney from a protein perspective, and that's very helpful in looking at trends. The other thing to look at, a lot of people ask, is how do you work out their EGFR? So that's normally their height. It's multiplied by a K factor. So here we use 40, other places do use a different K factor. So just go in line with your local policy and you divide that then by your creatinine, and that will give you your EGFR. Looking at renal ultrasound, it's an important modality and should be performed in certain circumstances. So within 6 hours, if you think there is a concern regarding a pyelonephritis or a renal vein thrombosis, and within 24 hours if you cannot identify a cause for AKI or you think there is an obstruction. Really, if there's an obstruction, I would like it sooner than 24 hours, but that's the current guidelines as per KDIGO. If you ultrasound during an AKI episode, you will find the kidneys are large and bright. A renal biopsy can be considered in those children who have nephrotic or nephritic presentations, and if they're rapidly, their renal function is rapidly deteriorating, and we do not know why. So this is just a nice diagram to sort of show you that until recently, progress in characterising events that follow an AKI insult have been hampered by a lack of a consensus definition of progression and its associated events. And following recognising this, a working group again, the Acute Dialysis Quality Initiative, sought to clarify these concepts, and they identified a clinical course of AKI and conceptualised it in events that followed an acute insult to the kidney. And there's 3 phases. So the first one is the development phase, and that represents the immediate effects of the initial insult, which may be subclinical. The extension phase then ensues, and that is in a point where both injury from the kidney and repair mechanisms are competing against each other. And then you have the resolution phase that represents the net outcome of both damage and repair. And the duration of each of these phases may vary considerably from child to child, dependent on the nature of the kidney insult and the repair processes. So I'm just going to try and talk you through these. So thinking about optimising kidney perfusion, minimising iatrogenic insults, control your acid-base balance and electrolyte abnormalities, and optimise urinary drainage. And I'll just talk through each of these separately. So these interventions should target removal of kidney insults and optimise conditions that then facilitate your adaptive repair processes. So optimising fluid and kidney perfusion. So fluid resuscitation we've already talked about. Fluid-wise, we would prefer that they have ongoing fluids or feeds given orally or NG, and if that's not possible, then IV fluids are fine, but do switch them over as soon as you feel that is appropriate. Strict fluid balance and daily weights are essential. I can't emphasise that enough. It's very helpful, particularly if you are in liaison with a nephrologist, they will want that. Initial fluid review should be carried out within 6 hours of admission and assess that regularly thereafter. Fluid regimes, adjust them on clinical response and subsequent electrolyte results. Maintain your blood pressure. So for this little girl, we held her atenolol. That was in liaison with cardiology. Be wary of stopping those kind of drugs unless you've spoken directly to their cardiologist, particularly in a cardiac transplant patient. Echo can be useful, and it was with her, and she still managed to have good function despite being hypotensive and dry. Just of note with regard to blood pressure, there is no evidence to support renal dose dopamine. That was an older practice, but that is not the case anymore. And fluid management then, so again, looking at your stage 1 AKIs, they really can have maintenance fluids plus deficit if you think that's necessary. Stage 2 and 3 do tend to run into more issues and are slightly more complicated. Once you feel that you have filled them up and adequately resuscitated them, and if you're still struggling from a urine out perspective, it is wise to replace insensible losses, so 400 mils per metre squared per day, plus mil for mil of what they are peeing out, and that should keep them safe and should stop them becoming fluid overloaded. Fluid deficit can also be given in stage 2 and 3, but carefully, and needs to be reviewed regularly. And then when you come to the renal recovery stage, you do find that these children become polyuric. So looking at those, if you find that there's 4 mils per kilo per hour of a urine output, you should be replacing that volume that's above that, either with IV fluids or oral fluids. And that's trying to prevent them from having a secondary injury from an AKI perspective. Minimising your iatrogenic insults. I've already talked about this from a drug history perspective. Renal dose adjust your medications as per GFR. Stop nephrotoxic potential where able. She was commenced on tazocin acyclovir. Was it necessary? She did not end up having encephalitis. She was drowsy, more likely so because she was hypotensive and hypovolemic. So always do think about it. TAC levels, so just so that you know, TAC levels do tend to go up with diarrhoea, so they do need closely monitored, and you may need a dose reduction in your tacrolimus level, but that can be led also by the transplant centres. Cotrimoxazole for her, just to flag that up as well, it is associated with tubulointerstitial nephritis, so she may have had something more unusual. So again, have a think about it. And atenolol, think about your antihypertensives. The big antihypertensives that we do worry about are ACE inhibitors and ARB, as they should definitely be stopped if they are having GI losses. Because they have a very high risk of causing AKI and should be restarted once they are better. And all of those children should have sick day rules with regard to those therapies if they're on them. Controlling acid base and electrolyte abnormalities, so address hyperkalemia. Okay, I'm not going to go through that. That's as per APLS, and we would stick with that. Severe acidosis compromises adaptive repair, so correct it where able. Giving sodium bicarbonate is fine, but you must ensure that your calcium is normal. And a quick way of doing this, if you have a gas in the ED department, if your ionized calcium is greater than 1, that's good. But do not give bicarbonate if it is. You must replace your calcium first before giving bicarbonate. You may require electrolyte supplementation, particularly during the polyuric phase. So they may need sodium, potassium, and magnesium and phosphate. So do keep an eye on those elements. Optimising urine drainage. So this is important if you suspect a congenital abnormality of the kidney or urinary tract. So that's what CACUT stands for. So those young babies that come in, it's a baby boy who is a missed posterior urethral valves. Catheterise them if you deem it is appropriate. If obstruction is suspected, get an urgent renal ultrasound. The guidance is 24 hours. If you can get it before that, that's great. And then you can try and remove and treat that obstruction and use your urologists. They will be able to help you with that. Delay in this compromises, again, adaptive repair. Those children that come in with a high potassium and a low sodium, think about them from a destructive perspective. They may well have pseudo-hypoaldosteronism. And once you relieve that obstruction, that should resolve. When do we want to know about them from a nephrology perspective? So as I've already mentioned, CKD and previous renal transplant, they are at risk. So we do want to know about them. AKI associated with multisystem disease, if they're hyperkalemic unresponsive to medical management, if they're anuric or oligoanuric and their plasma sodium is less than 125. Pulmonary edema or hypertension unresponsive to diuretics. If their urea is greater than 40, so uremic children become unwell, they do not want to take fluids, they will not take solids for you, and they will progressively become more lethargic. If they have a glomerulonephritis with a nephrotic range urine protein creatinine ratio, so anything over 200 from a urine protein creatinine ratio is nephrotic range, we would want to know about that. And stage 3 AKI, definitely. Stage 2, very happy to also have a discussion about those children. And then moving on to renal replacement therapy. So this is an entirely different talk in itself, but really I'm just going to talk briefly through the indications for this. So again, hyperkalemia, volume overload, metabolic acidosis that is refractory to medical management, symptomatic uremia, if they are anuric and you're struggling with regard to nutrition and volume or toxin removal. So it can be very helpful. Renal replacement options. So if you're in the PICU setting, CVVH is the one I think that most people would opt for. It's a gentle form of renal replacement therapy. PD can be used in the acute setting and we would use it very regularly, but it does take time to optimise it to good levels and does require no leakage of the catheter. So it is an option, but it can be difficult to establish. Hemodialysis and HDF, they are forms of renal replacement therapy, difficult, and would not use those in children who are very unwell and unstable from a clinical perspective, as they cause large fluid shifts and electrolyte shifts. So CVVH would be a better option for them. So progress for our child, so her creatinine peaked at 220. She did not require inotropic support. She did not need filtered and she did not need ventilated, and that was because of careful fluid management from the outset. She completed 5 days of tazocin. Her acyclovir was stopped on day 2. All of her cultures were negative, including her virology. So again, thinking back to that acyclovir, was it needed? Her blood film at the time, she had low neutrophils. It was all reactive and felt very much to be related to her concurrent illness. She was discharged from PICU on day 4. She did have a phase of polyuria, which was ongoing, and GI losses, but they settled by day 6. And she now has a minimum fluid target of 1,400 mils a day. And that is a strict care plan for her and very strict parameters for parents about when they must seek medical attention. And she was discharged on day 10. Subsequently, unfortunately, her CKD has become worse due to this hit, and she's now sitting with a CKD stage 3B and 4, really just highlighting again how important it is to manage these children well. And unfortunately, she is on a number of supplements now, including EPO, because of her CKD, and she's got progressive bone disease. AKI outcome. So why is this important? Why am I talking to you about this today? So this was a good study done in Israel. So it was looking at Israeli adolescents who were examined before compulsory military service, and their data were linked to the end-stage renal disease registry within Israel. And anybody that was coming through that had a kidney disease in childhood, either acute, pyelonephritis, glomerular disease, were all looked at, and they all had normal renal function and no hypertension in their adolescent years. However, in their adult years, there was a significant increase in end-stage renal disease that really suggests that kidney injury or structural abnormality in children has got long-term consequences. And these are just some other studies. Again, this was an American study that really identified that chronic sequelae of AKI is under-recognised. A third of 176 children who were looked after in this centre in both the PICU setting and the ward setting had reduced kidney function or remained on dialysis at the time of discharge. And on a 3 to 5 year follow-up of the cohort, 58% had long-term effects, including hyperfiltration, reduced kidney function, hypertension and proteinuria. And the second study is just, again, it was 126 children treated in an intensive care, and 10% of them had CKD within 1 to 3 years following an AKI. So again, compelling evidence that we do need to take this seriously moving forwards. From a follow-up perspective, stage 2 and 3 AKI should be followed up at 6 weeks, 3, 6 and 12 months. At that clinic review, I would expect a manual blood pressure, their bloods to be checked and their urine to be dipped and their urine sent off for a protein-creatinine ratio. So basics, nothing complex, but it will identify those children who are running into trouble. All children who have required dialysis, including those who have CVVH, or who have persisting proteinuria or renal dysfunction at 3 months of follow-up, should be referred to a tertiary nephrologist or SPIN paediatric nephrology. So in summary, AKI is associated with increased mortality and long-term CKD, and I hope I have convinced you of that today. Early recognition is paramount. Creatinine only rises in 25 to 50% of renal function, so taking that good history and looking at your drug history and getting the families to seek medical attention early is important. There is a role for biomarkers, and future studies will evaluate those further. Volume resuscitation and fluid management is key. And a very important cornerstone of your management. Identifying potential nephrotoxic agents and ensuring renal dose adjustments are made where appropriate. And all patients with AKI stage 2 or 3 require long-term follow-up to mitigate progression to CKD. I'd just like to acknowledge my department here, and I'm very happy to take any questions that you have. Thank you.